Hi, everybody. This is Rajam Roos, CEO and founder of the San Diego Pain Summit, and I'm joined today with Sarah Haag, who is joining us from Chicago. And she's a physical therapist who graduated from Marquette University in 2012 with a master's in physical therapy. She's pursued an interest in treating the spine pelvis with a specialization in women's and men's health. She was awarded the Certificate of Achievement in Pelvic Physical Therapy from the section on Women's Health, and she went on to get her doctorate of physical therapy and Master's of Science from Rosalind Franklin University in 2008. And Sarah looks at education and a better understanding of the latest evidence in the field of physical therapy as the best way to help people learn about their conditions and to help people learn to take care of themselves throughout the lifespan. So welcome, Sarah, and thank you so much for joining us today.
Thank you for having me.
So I thought it was interesting. We were shooting emails back and forth, and you were talking about the idea of this Venn diagram of pain and dysfunction, and how people are almost our clinicians seem to be looking for dysfunctional movement as the source of pain. And I just thought that sounded really interesting and wondered if you could talk about that a little bit more.
Sure thing. So we know that like the understanding of pain and pain science and some of the things that are contributing to some people continuing to hurt when other people don't. So we have this much more broad understanding than I had when I was in school 20 years ago. And yet, if you just Google like physical therapy continuing education, or honestly, it's available to personal trainers and athletic trainers, this idea of looking for dysfunctional movement as a way to treat pain and potentially prevent pain. And it always gets me thinking, because if only it were that simple, joint replacements would be perfect. And
so you mean like have like a if we can prevent this movement dysfunction, then we can prevent pain. That's what you mean on that aspect?
Yes. So that is how some things are sold. And there are things that are certainly ways of moving that are certainly more efficient, but there really aren't many movements or activities that you could do that would be inherently bad for your joints or your body, or that would necessarily lead to pain. And so I started to think, because sometimes it does matter, right? So like some people feel way better if they put in an orthotic. Their foot feels better with some support. That's real. However, does that mean everybody who has a flat arch needs an orthotic to give them an arch? No. A lot of people have super flat feet and are totally fine until someone tells them they're not. They try to make it even better. So in my brain, there's kind of this Venn diagram where there's sometimes things that are not working very well. So be it a joint, be it a nerve, be it a muscle it's uncoordinated or it hurts when you use it. So there's things that can happen, but then also there's pain. And we know that people can experience pain and look beautiful and move beautifully and be super strong and or super flexible, but yet they still have pain. So I find it fascinating in this realm of people who want to help people feel better, who keep trying to tackle a dysfunction without having that discussion of how much might what I'm seeing with my eyeballs actually, or feeling with my hands in some cases, how much does that actually contribute to this person's experience of pain?
And how does a clinician make that jump, from, if that's our training where we look at this is what we're supposed to look. Are there any ways that they can kind of make that jump over to maybe not consider that as so important?
I think so. I think the way I've gone about doing it is, one, I started just asking. So the older I got, the more I got like an annoying 3-year-old. I'm just like, why? So then that's kind of like another, like in my head, I have like this whole flow of things, because so what do you do? Right. So we can only, I have a slide that I've been using a lot that I made, because really, speaking from a physiotherapy background, is the only 3 things we technically have to offer someone is we can educate them, we can have them move, or we can touch them. And so then under those three general categories, I mean, that goes everything from any manual therapy technique, including joint mobilizations or manipulations and any soft tissue work, to basically any exercise or any form of movement. And of course, education is primarily teaching, interacting, trying to understand what they're thinking, and maybe look at maybe understandings that are inaccurate or outdated, and try to help them find a path to like a better understanding, which hopefully will make them feel better on some level. So what I would say is that what we need to do is to step back, and whatever our modality is, touching, talking, moving, whatever, and go, why am I doing this? And what do I think I can actually change with this? So some people will, I'm going to use scar tissue as an example. Part of your problem is the scar tissue causing dysfunction. Well, scar is pretty amazing, and it has basically one job of closing up so that you are safe from infection and your insides don't fall out and you don't bleed to death. So its job isn't to be pretty, and it actually isn't really to be very mobile. And when we try to change the structure of scar tissue, there's a reason why it's often not very comfortable, and very often doesn't actually change the scar. Now, it can change the sensitivity of the area. It could change the mobility of the tissues around it. It could improve tissue mobility, and then maybe the mobility of surrounding tissues and joints from there. But you know, understanding that what I can change and what I can't is, I think, a really good place to start. So like if I mob a joint, I'm not changing their cartilage or their joint space or anything. What I'm doing, I think, is really up for discussion. But some people who like that really like it and feel like they can move better. I'm good with that. But I feel like it's mostly a change within that person and their perception, more so than what I'm doing in any kind of peripheral tissues.
So that's where the conversation with them, asking them the questions, comes in, because if they feel like it's making a difference, then why not, right?
Right. And that's real. And then we still need to ask that question, why, and how do we keep going? So if we do something, a manual technique, a movement in particular, whatever we do, then the question is like, did that make you better or worse? Or didn't really change anything? And if it made you worse, typically that's probably not a route to go down. People already feel bad if they're looking for help. We don't need to make them feel worse. But if they did feel better, we still need to keep asking those questions. Why? It could be because you like the sound of my voice. It could be that you won the lotto on your way to the clinic. It could be that you got a new puppy on your way home. Like, there's a lot of things that could impact why you felt better after doing something. It's not, I always talk about it being more like a mosaic, is there's a whole bunch of things going into that experience. And what you see is the overall experience. To figure out that piece that they can control and that they can change and be in charge of is kind of the fun part. And it really shouldn't be me being the fun part. I mean, hopefully I'm fun when people are interacting with me. But you know, if I touch you in some way and you feel better, how can you do that more often? Because I'm amazing, but I'm also not cheap. So you shouldn't have to come see me every day so that you can get through your day. What can you do at home so that you can get through your day and get through your day a little bit better every day? Same thing with a movement or an exercise. And I'm okay not understanding all the whys right now. There's people with way higher degrees and way higher pay grades than me who can really try to figure out all of the mechanisms of that. I'm okay going, we know this stuff doesn't work, and we know that the stuff we're doing doesn't work like we thought it did. But if we keep asking why and how do we get it to persist, then I think we're going to be much better at our jobs.
So it sounds like you're talking about, well, there's a few things. One is being more comfortable with ourselves as clinicians to say that we're okay not knowing why every detail. And then also something you said, touched on earlier, besides apparently giving your patient self-efficacy, is what do you have to say about that thought idea that things need to hurt worse before they can get better? That seems to be kind of a prevalent idea in manual therapy, or it was a few years ago. I'm not sure if it is now, but that, it's okay if there's a lot of pain because you're going to have to go through that first. And I think they call it healing crisis or something.
We keep making it harder than it seems like it should be. Why do we have to go through a crisis to heal? So I'm not familiar with that term, and I would like to think that we are very cleverly designed, and healing happens in spite of us, right? Like we get better when we have tissue damage or an injury. Thankfully, also medical science has come a long way, and we don't have terrible infections anymore, and we don't, there's a lot of things that that just happen, and I would say that's not a crisis, that's just healing. As far as having like rehabilitation or restoration of function have to hurt, I mean, I grew up in the 90s where no pain, no gain was like the thing. I don't know where or why that came from. I want to say that it was probably more of an athletic background, where, to be perfectly frank, when I'm running really, really far, I don't not hurt. But also I know why my tissues are tired, and I'm tired, and my brain is tired, and I'd really like to stop running now, except I'm not home yet. And so that kind of pain where you're kind of pushing through your edges of where you are currently can be uncomfortable. I think there's a difference between I'm going to work really hard and to get stronger or to get more flexible. We need to challenge and stress our tissues, and that might not always be the most comfortable thing. But I think if we think about it like after you sprint really fast and it hurts to breathe, that goes away in a second. And that makes sense. We understand that. When I lift weights or try to do a pull-up, the next day I'm sore, but like it's understandable. I get it. And I know that needs to happen for me to get stronger. Now, some people going through rehab don't understand some of that I would call it kind of normal discomfort, and it's threatening. So like that kind of hurt, I'm okay with that. But this idea, and those are physiological processes that are happening. This idea of manual therapy, or honestly, even like exercise in general, I would say we don't have any evidence that should hurt or that it needs to hurt. And I would say most of the time, if there's going to be, especially in like acute post-surgical, right? It hurts to get out of bed after you've had an abdominal surgery. You got to do it anyway. And we can say with great certainty that should keep getting better and better and better every day. This idea that 10 years after your C-section, I need to dig into your gut and make you scream to move that scar, there's no evidence that says that's necessary. So I would say that if we're thinking very acute things, that should have a predictable decrease in pain over time. When we get into more uncomfortable things, like uncomfortable manual therapy, we have to ask, why are we doing that? And what do we think we're changing? Especially if that person in front of you is already in pain.
Yeah, it's funny because I used to, when I had my massage practice, I would get clients who would tell me a treatment they went through and it was extremely painful and they were gritting their teeth. But when it was over, wow, they felt so much better. And I used to wonder, is that because the painful treatment stopped? Or were you actually feeling better from before you came in? And I would even ask that question a few times and the client would be like, I don't know.
So with that's there's a couple different like choose your own adventure stories there that because people will ask for that. They were like, can you dig in more? Can you make it like, they think it needs to hurt to make them feel better. And what I love, speaking with some of my manual therapy colleagues out there in the world, is that they are taking the time, instead of just giving the customer what they want, is to go like, I hear what you're saying, but what if there was a way for it to not have to hurt and you feel better? A lot of people are like, wait, that's an option? I didn't know that was an option. I'll take that option. That sounds better. Other people do like it. They like the pressure. And even if they're kind of like, like you're getting in there and they're making the face, but if they like it, it's not pain. So there are people who do things that would make me cringe, but they like it. It doesn't hurt. Not a problem. So I would be very curious of the situation there, is if people were given an option to have a not painful treatment on top of the pain they're already seeking treatment for, would they pick it? Which again leads to another discussion that I think needs to happen more often, which is, does the clinician believe it? Does the clinician believe that they can touch a person in such a way and have them feel better without using aggressive techniques? Because if the practitioner doesn't believe it, I don't know how effective it will be.
Or if the practitioner believes that they can palpate sacral movement, or they can break up scar tissue. I think those types of beliefs it definitely would have to be changed before. I would think they would need to be changed before they could actually listen to their patient.
Yes, I think probably. And that can be really hard. Like when if that's the way we've been trained, and if we've had an experience where that seemed to be the case, and if that's the way I've practiced for 20 years, it is hard to make that change, for sure. And even with those practitioners who utilize painful techniques and find in their experience that those painful techniques are very effective at treating pain, how can I say this? One, that I truly believe that they're doing their best for the person who's come to them for help. So I believe that they believe it's the best thing to do. But also, and this is hard even when you're keeping up with the evidence and you're trying to do the most evidence-based care and you're trying to listen to your patients and get all of that information, is that, as I said earlier, people get better. There's regression to the mean. There's natural history. And that happens in spite of us. So sometimes we happen to just be in the vicinity when someone started feeling better. And then all parties involved attributed that recovery to whatever magical thing we just did. And while that feels very good for the ego, I think more often than not, it's just luck and the right place, right time.
Yeah, I used to tell my clients, if they came in, especially with back pain, if they were very concerned about it, I would let them know, well, within 6 months, it's probably going to go away. So you actually don't need to come in and get massage if you don't want. And most of them still wanted to try it.
Yeah.
But it sounds like, being open with your patients would be counterproductive for your work, but it actually enables them to trust you more, I think.
I hope so. And certainly, it's not a sure thing, because sometimes people want to be told exactly what to do, and they do believe that you're going to help them, which is flattering and nice. And, so what's really nice is when you get to have that conversation with your clients or your patients or whoever you're seeing, and have them truly decide what they would like to spend their money on and what they think they're getting out of it. And as long as you're very honest about what you have to offer, I think that's fair. People can pay for whatever they want. But it's kind of tricky when they've been told in the past that you need to come see me twice a week, like for 6 months so that you can get better, when actually they probably would have gotten better anyway. So it's kind of tricky. And we want to be helpful. We want to do good things for people. And also we need to be mindful of how we're perhaps making people not get better as fast as they could be if we had gotten out of their way.
I like that. Yeah, because, when we're talking about having less than optimal anatomy and good function.
Mm.
So I walk with what's that called again? Your feet
That's
are
pronation.
Pronation. So I walk pronated and probably have my whole life. But I had been when I had taken continuing education classes, so many people were pointing out how, the structure, I'm doing all this stuff to my structure. I need to do the 3-point and focus on that. So I did. I focused on putting a little more weight on the outside of my foot to think of that 3-point.
Mm-hmm.
And I gave myself shin splints.
I'm sorry, I'm not laughing at your pain. But right?
And I was like, oh, screw that. I mean, and it was right when I was learning about all this stuff about, I was slowly changing from, throwing my clients up against the wall to measure them and palpating stuff as they were moving. And I was like, there's a perfect example. There's nothing wrong with my pronated feet. They work just fine.
Right. And again, sometimes we try to make people picture perfect and it doesn't feel good. So really, what are we aiming for? People feeling good or people looking good? And that's kind of a beautiful segue into stuff like alignment. And because I hear pelvic dysfunction all the time. And there are some times where things get a little bit sticky or things don't move like they should or things feel off. That's all very, very real. But so often I hear people like, I'm out of alignment. And when we think about what alignment is, most of the time, they're feeling it when they're moving, but they're only being assessed when they're static and in one particular position, right? So all of our joints have give and movement, active and passive, differences in range of motion. So like I can only take my hand to here actively, but I can like go to there, right, with some overpressure. So there's, so I start to ask my patients who are really caught up on their alignment, because they've been told their pain is because they're out of alignment, is to really get a better idea of how does it feel when you move? And I try to explain that even if you've had an x-ray, right, you're taking an x-ray in a static position, and that is literally a snapshot. If that's the only time you hurt, maybe it's giving us some information, but most of the time we're moving through life. And so this idea that we got you in perfect alignment right here, don't move, I'm going to throw it right out, is it's unhelpful because one, we've learned more and more that isn't actually telling us much. And I learned it. Oh man, I would look with like one eye. I would get it. I would get it really right. Never. And so I do still check those things on my patients who tell me they're experiencing these things, because I want to see if I can see what they're feeling. Does that even make sense? But I want to see, and most of the time it's not as like, they're like, oh, it's like 2 inches. And I'm like, actually, if I give you just a little tug, you're kind of okay. And when they stand up, they're fine. And, just trying to figure out, I tried to get them away from that idea of some kind of static form of perfection and get them to be not afraid to move. Because that's the other thing, when we get people into good alignment, they want to stay there. And they do that at the expense of not moving anymore. So like I was told that when I do this movement, I fall out of alignment. Well, can you do it on the other side and just see what happens? So let's see if you can fix it if you're really falling that far out of alignment. Because to be perfectly frank, there are some conditions like Ehlers-Danlos where your ligaments don't do a great job of holding all of your pieces where they belong. Most of us, your pieces aren't going anywhere. If they feel like they're out of alignment or they're not moving very well, honestly, the best treatment that we have the most evidence for is to have you move them. And to be fair, someone else could move them for you, but it's probably better if you can get them moving yourself as well.
What are some ways that you would communicate to a patient who really believed that when they moved a certain way, they were completely out of alignment? What does that conversation look like to kind of shift their mindset onto what is really going on?
I try to get them to experience it with me in the clinic And so what I mean by that is like when they tell me they're feeling a particular way, if they want me to, I will do a couple different assessments, like see, how do you do standing on one leg? And how does it feel when I wiggle your pelvis passively when you're lying down? And just kind of see how that feels to them and their perception of it. Sometimes stuff can feel a little stiff, but I try not to say that out loud because that's just my perception.
It feels like it's locked.
It ain't moving anywhere. Also, it's very out of alignment. No, unhelpful. So I check the things that they think need to be checked, and I give them my honest opinion. And I have only, I think, once or twice in almost 20 years of practice actually seen someone who was like, oh, that probably would feel better if it wasn't stuck in this position. And again, though, the answer to that is to get it moving, not to find a new static position for it to live in, because everything needs to move. So some words. So one, I would check the things I wanted to check and reassure them of their stability and safety, and then actually to get them moving. So you tell me you feel out of alignment. When do you feel that? Like, it doesn't count if someone just tells you you are. Tell me when you feel that. And let's see if we can change how that feels. Because sometimes, it's a little bit different because of just the motor pattern they have when they're standing on one leg or going upstairs. Sometimes it is that one side of their pelvis seems a little bit less mobile and it doesn't transfer load very well. So then if they get that wiggling and moving, they can notice a change. And if we can find something simple for them to do on their own that restores that feeling of stability and maybe even alignment, excellent. So, right?
Alignment.
Exactly. It's like one of those things where like something like bad posture. And I want to say that it might've been an Adam Meakin's quote. He's like, I'll tell you what, I stood perfect when I was a soldier, and that starts to hurt too. Like, it's more the lack of movement that seems to be the issue, as opposed to the lack of finding a perfect place to be in forever. And then sometimes I will try to make it make sense for people, like if they have pets or ever watched an animal show, like watch how your cat sits, watch how your dog sits. Also watch how long they stay in that position. They get up, they walk around, and they turn around the other way, and then they lay back down.
Unless there's a sunspot.
Unless there's a sunspot.
For the cats. They
Right?
get up eventually, though, I think.
Right. But also that's like also a matter of priority. We've all been in a situation where like our butt starts to fall asleep or our ankle feels a little weird, but we're like, maybe you're on that perfect date and you don't want to be too wiggly, or maybe you're like crammed into the middle seat of the airplane and you're landing in 10 minutes. You're like, I can do it. I don't have to wiggle that much. But that's a choice and a prioritization. Right. So, but a lot of times I think we expect ourselves for some reason to be perfectly still. Like, I know I've been kind of a squirrel because I'm sitting on the floor, that people have this expectation that because I can't sit perfectly still and be comfortable for my entire workday, that there's something wrong with me. And, it's like, it's not bad posture and it's not dysfunction. It's like, you need to move.
So it's a matter of just changing their mindset about what they think about that.
Yeah. Yeah. And that's not always easy. So again, instead of like pulling out my pain science book and giving them a lecture on why their alignment is fine, I would rather have them just feel it and find things that do feel better. And sometimes things don't feel good because they're stiff. And then I will ask them, so if you have something that is stiff at home, a door, a window, what do you do with it? And they're usually like, well, I kind of wiggle it, or maybe I get some WD-40 and I work it loose. I'm like, brilliant. Let's try that. Because of course, if I'll actually use the example of splits a lot. I'm like, or running a marathon. If you've never done that and you try to do that today, there's a very good possibility it's not going to feel very good. However, if we start small and we start getting things moving, or we start building up those tissues' tolerance to load, there might be some growing pains, but really it should start feeling better and you should see a change in your function. But definitely, like if your door was a little bit sticky and you just stopped opening it, one, you can't get out of your house. That's a problem. Two, it's not making that door move any better. So we have to come up, again, change the things that we can change, and not worry too much about the things we can't.
So on that note, considering this discussion, what are some things that you think somebody watching and going back to work later today or on Monday, what do you think they can take from this and start using with their next patient?
I would say maybe one or two or 3 points. One is that there is no such thing as perfect alignment. And if there is, it's fleeting at best. So to remember that we have all of these joints and all of these muscles and all of these nerves so that we can move. If someone has something that looks not good, and they seem to attribute their pain to something, try to get it moving. If they've had trauma, please send them to the doctor. But for the most part, it's like, if my one shoulder is a little higher than the other, this could be my anatomy. I could have scoliosis and have my shoulders be like this and have no pain. But if you see something that seems to be perhaps a contributing factor, see if you can change it. I would encourage people to try to find ways to encourage more movement of tissues, joints, people in general, to find a way that doesn't hurt more. Pain is very motivating, and it's awesome whoever got everyone to think they had to hurt more to feel better, because that's a hell of a marketing plan. But really, we don't have any good evidence that you have to hurt people for them to get better. In fact, that goes against logic. And any place else in the world where you hurt people, you go to jail. It's assault. So I have permission.
That's a really good
right?
perception.
Try not to hurt them more, because we just don't have good evidence that is a way to go about it. And if you're not sure what else to do, I'm going to throw out a plug for the San Diego Pain Summit and courses that we have at Entropy, to be honest, where you can have a kinder, more gentle, and we're hoping more effective way of getting people to hurt less and do more. Now, granted, if we're looking at like movement dysfunction, I don't really know exactly what that means sometimes, but people see it everywhere. Just understand that you don't have to be perfect in any way to not have pain. So quit trying to fix people's feet when they're not hurting. If they're not hurting, leave them be. If they want to do more and start to experience pain, then we can start to problem solve. But for the most part, I think we make it hard. I've been talking too long. That for the most part, what I think what we do is we just make it harder than it needs to be. So step back, keep it simple, and don't hurt people.
Well, thank you so much, Sarah, for your time today. And I really appreciate it.
All right. Thanks for chatting. I love it.